Hi students, let's look into a small chapter today, Gingivectomy and Curretage. I have referred Currenta's 13th edition. There are only 13 slides in this presentation. Moving on to the presentation. What is gingivectomy? As we all know, ectomy refers to cutting. So gingivectomy means excision of the gingiva. We know a periodontal pocket has a pocket wall and a tooth surface wall. So by doing gingivectomy, we are removing the pocket wall, and this provides visibility and accessibility for calculus removal and root planing on the root surface. So this creates a favorable environment for gingival healing, as well as it restores the gingival contour. When we are cutting the gingiva properly, it gives a proper contour to the gingiva. So to provide gingival healing and to get a proper contour, can we use gingivectomy in all cases? No. There are specific indications and contraindications. The indications are only two. Only when the pockets are suprabony and the pocket wall is fibrous and firm, you can use a gingivectomy. It is not meant to be used in an infrabony pocket or when the base of the pocket is below the alveolar crest. And one more very specific indication is for the elimination of gingival enlargements. Like you have a drug-induced enlargement and all, which is severe, you can go for a gingivectomy to get a proper contour. So these are the indications. Very importantly, only for suprabony pockets and only for pocket wall which is firm and fibrous. Contraindications, as we already mentioned, when we want an access to the bone, we are not supposed to cut all of the gingiva and expose the bone. And when the zone of keratinized tissue is very narrow, you are not supposed to cut the gingiva and lose this whatever narrow zone which is remaining. 3. Aesthetics. Whenever after doing gingivectomy, if it is not going to provide aesthetics to the patient, it is contraindicated. And finally, a patient with high risk of postoperative bleeding is a contraindication for gingivectomy, because after gingivectomy, we are getting an open raw wound. So patients at risk of bleeding are not supposed to go for gingivectomy.
So coming to what is the instrument that is to be used for gingivectomy. The typical instrument is Kirkland knife. It is the representative of the knives that are used for gingivectomy. It is kidney shaped, and the entire periphery of this kidney shape is used as the cutting edge. You have to be familiar with the figure. The first one, or A, is the Kirkland knife, which is kidney shaped. The second one is the Orban interdental knife. It is a spear shaped knife. Similar to Orban, we have Merrifield knife, which is also a spear shaped knife, and they have cutting edges on both their sides. And the same spear shaped knife with sawtooth indentation is known as a Werehog's knife. So Kirkland, Orban and Merrifield and Werehog's. You have to be familiar with all the terms. Now we have the 12D blade, which is a beak shaped blade. The 12 is a C shaped blade, and the 12D is when its both edges are used as cutting edges. We also know 15 number blade, which is used for thinning of the flaps, and a modification is 15C blade, which is a narrower version of 15 number blade. So all these can be used for gingivectomy. Now difference between two terms, electrosection and electrocoagulation. Electrosection is also known as electrotomy or accusection. It is used for sectioning. From the term it is clear. So it is for incisions, excisions and tissue planing. What is electrocoagulation? Again, it is clear from the term, it is coagulating. So it provides coagulation and hemorrhage control by using a coagulation current. Clear? Going a bit into history, because author names have also been asked as MCQs. Who gave the procedure gingivectomy? Robišek was the person who introduced gingivectomy. And when Robišek introduced gingivectomy, he followed a straight line contour of the gingiva. The scallops of the gingival margin was not followed. He followed a straight gingivectomy. This scalloping was introduced by Zentler. SZ, scalloping by Zentler. But the gingivectomy procedure, as we do it today, we do the using a pocket marker, we mark the points, and we do it in a proper scalloped way. This procedure, as it is employed today, was given by Goldman in 1951. So first by Robišek it was straight, later modified as a scalloped one by Zentler, and as it is today, gingivectomy was introduced by Goldman. So these are the steps. The pocket markings have been made with a pocket marker. Then we are giving incision, an angulated incision, apical to this. Okay, apical to the pocket, we are giving the incision. After that, we have to give an interdental incision. Look at the figure, you can see the spear-shaped knife with sawtooth indentation. This is the Werehog's knife. So we use this for incising the interdental area.
After that, the detached gingiva is removed with the scaler. This is the procedure. Now another important area is healing after gingivectomy. So it is pretty long. For the ease, I have divided it into two parts. What all changes take place in epithelium and what all changes take place in connective tissue. In 12 to 24 hours, the epithelial cells at the margin of the wound will migrate over the granulation tissue which is formed. We know it is a healing by secondary intention. So granulation tissue will be formed. In 12 to 24 hours, epithelial cells will start migrating over this granulation tissue. In 5 to 14 days, surface epithelialization will be complete. So epithelialization is completed by 5 to 14 days in almost 2 weeks. But complete repair of this epithelium takes place in about 1 month. So in 1 day almost, the cells migrate over the granulation tissue. In 5 to 14 days, surface epithelialization is complete. In 1 month, this is completely repaired. In connective tissue, what all are the changes happening? By 24 hours, there is increase in the number of the angioblast. So, it is going to help in the formation of blood vessels. By third day, the number of fibroblast increases. Okay, fibroblasts start appearing by third day. This is a very important question. What is the change that happens on the third day? They can ask, or fibroblasts start appearing on which day also they can ask. Then the granulation tissue which is formed will start growing coronally. By 2 weeks, periodontal ligament blood vessels will connect with the gingival blood vessels. We know by 24 hours the number of angioblasts had increased. So, blood vessels were formed. By 2 weeks, the blood vessels which were formed in gingiva connect with the periodontal blood vessels. And by 16 days, almost by 2 weeks, a normal vasculature is established. And the complete repair of the connective tissue takes 7 weeks. Epithelial repair was complete by 1 month. Complete repair of the connective tissue takes almost 2 months, so that is 7 weeks. With that, we finished the important points about gingivectomy. Now, curettage. The first thing I want to tell you about curettage is an obsolete procedure. It has been taken away from the periodontal procedures by AAP in 1989. They said curettage should no longer be performed. So, but we have to learn it. It is our bad fate. So, curettage is done with curettes. Curettes are the instruments which is used for the debridement and scaling, both for the supragingival and subgingival areas. The type of hand instrument that is most suitable for a subgingival debridement is curette. We know it is not sharp, it has rounded margins, so it is not going to harm the gingiva. How do we do? After the base of the periodontal pocket is identified with the lower edge of the blade, instrument is turned to a proper working position. What is that position? The shank should be parallel to the long axis of the tooth. Then we use pull strokes to do the curettage. Results of removal of epithelium by curettage vary from a complete removal to persistence of as much as 50%. Okay, so sometimes we were very successful in removing the epithelium. By the way, what is curettage? It is the removal of the epithelial side of the pocket. So, when we treat the epithelial side of the pocket, what was our idea? This side is infected, so we have to remove this infected part. So, sometimes we were very successful in removing this. Sometimes we were leaving behind as much as 50%. But why AAP considered it obsolete? Because AAP was suggesting the main irritant lies on the tooth and the root surface. And because of this only, the soft tissue is reacting. So, whenever we clean the tooth and the root surface properly, the soft tissue is going to heal automatically. That is why AAP suggested curettage should no longer be performed and it is obsolete, right? So, by what all methods we can obtain this removal of the epithelial side? Ultrasonic method we can use, lasers can be used, rotary abrasives can be used. We also have chemical agents. Chemical agents can be used to remove the pocket epithelium in conjunction with curettage. Which are the agents? Most often sodium sulfide, phenol, camphor, antiformin and sodium hypochlorite were used. And already it is an obsolete procedure. In that, the use of chemical agents was strictly not recommended because the depth of penetration of these agents is not controllable. We intend to remove the epithelium, but it can go deep into the connective tissue and damage. Okay, so just remember these names. These agents were used as chemical agents for curettage: sodium sulfide, phenol, camphor, antiformin and sodium hypochlorite. When we were performing Curretage, one advantage we were thinking we are getting is it excludes the epithelial and connective tissue migration, and it is similar to the principle of GTR. We know what is GTR, or guided tissue regeneration. After periodontal surgery, the cells which first repopulate that area is going to determine the type of healing. Like if epithelial cells are coming and populating that area, we are going to get a long junctional epithelial formation. If connective tissue cells repopulate the area, then we are going to get a proper connective tissue periodontal ligament attachment. And if bone cells are coming and populating that area, we are going to get an ankylosis. So this is the principle of GTR. So what was our main aim? To exclude the epithelial cells, because we know junctional epithelium is a weak attachment. So while we were doing Curretage, we were thinking we are getting this epithelial and connective tissue migration exclusion, so that we are going to get a proper periodontal healing. But due to the need for multiple visits and supplemental surgical procedures, it is not at all reasonable to use Curretage as a method of GTR. So we have better alternatives for GTR, and we have many biological agents available for this purpose. So that's all you should remember about gingivectomy and Curretage. Not much questions have been asked, but be clear about the concepts. If you have any doubts, you can contact me. Thank you.